Hi Sienna, this is Pieter, the surgeon from Aspitar. I'm going to give you two cases. The first one is an ACL rupture in the knee. It's very typical for football players. Unfortunately, it normally happens with a non-contact, what we call valgus alignment trauma, where the foot gets stuck in the ground, in the grass interface with shoe and grass, and then the knee twists, and then you get a rupture of an internal stabilizing ligament in the knee, which is called the ACL. It's a terrible injury for a football player, keeps you off the pitch a long time, and can also be related to other injuries, which we call the triad, which involves the meniscus, the ligament, and the internal MCL ligament. So with that, what's the cause of the injury? It's a rotation with the foot stuck upon landing or twisting in football. The diagnosis is that you hear a pop during the injury, and that afterwards you get bleeding in the knee and loss of extension and deflection with progressive instability upon walking, like stairs and sports. In order to diagnose it, we nowadays do an MRI scan. It's called a magnetic resonance scan that can identify very clearly not only the injury, which is the ACL rupture, it's called the anterior cruciate ligament rupture, but also can see combined or concomitant lesions like meniscus and cartilage, which is commonly also unfortunately involved into the injury. If it's an isolated ligament injury, there is data that shows that you don't need to do surgery immediately. But if there's combined lesions like rotatory instability or meniscus lesions or cartilage lesions, then we advise, especially in elite athletes, to do surgery in order to regain stability. Unfortunately, the damage that is done over the cartilage keeps being done, but the stability we can regain. And sometimes the other lesions can nowadays be treated as well. So is surgery necessary in the elite athlete with combined injuries? For sure. And we have techniques for that in order to refix the stability by reconstructing the ligament, meaning we remove the bad tissue and we bring it in with another type of tendon, like a hamstring tendon or a quadriceps tendon or a patellar bone tendon. The recovery time is between 7 and 9 months, which is a long time. And in the beginning, the patients have like 3 to 4 weeks difficulty in walking, but then the rehab starts, and the complications for these injuries are mainly blood clot and infection. Now, blood clot is being treated with low molecular heparin after the surgery, which is a preventative tool in order not to have the blood clot. And if there's an infection, we have to give antibiotics, or sometimes what we call an arthroscopic lavage, which is putting a lot of fluid into the joint in order to dilute the infection. The progress in rehab is very detailed, is very stepwise. It's not about time, it's about reaching criteria in order to go to the next phase. And actually Aspitar is a world leader on that, with a lot of research and a lot of impact throughout the physiotherapy rehabilitation centers in the world who treat these athletes with these conditions. The long-term effects on performance are what we call degenerative problems like osteoarthritis, and the ACL surgery is not really stopping that cascade. But when you have better stability, you can protect the structures more, you can play better. And in the end, the athlete that had the damage before will have an earlier degeneration afterwards. How to prevent it? Well, there are clearly preventative guidelines now through the research and rehabilitation, where up to 30% of players can be prevented into identifying the intrinsic but also the extrinsic risk factors in order to reduce the amount of injuries. So intrinsic would be like your own alignment that can be altered, but extrinsic can be the way you land or the way you move and the way you get training in order to prevent furthermore. The return to play, as I said, is normally between 7 to 9 months. Some are earlier, some are later, but the data shows that that is the moment where you have biological integration of your reconstructed ligament and you are more in the safe zone. There's much more about it, around alignment, around youth, age, and so on, that are predictors for new problems or re-ruptures, which are between 20 and 30%. So that's not little. But in the end, it's all about getting your athlete back and not only treating the player, but also preventing the injury. Next one is an Achilles tendon rupture in a football player. It happens due to an eccentric explosive movement, which is like reaching for a ball. And that's why it's very common also in sports like tennis and not only in football. The diagnosis is made by what we call the Thomson test, Thom, Pson. And you can Google that and you can check how that works. The diagnosis is clinical, but you can always do an MRI to see if there's any other injuries and what is the type of retraction. And the treatment for that is both ways. So you can have very good results with non-surgical treatment. You put them in a boot and do physio and they are doing well, or you can do surgery and fix it together. Both heal well. It's all about the time to return to play and the re-rupture rate, where surgery is more performing. So is it necessary? For sure not. It all depends on the retraction, on the type of athlete or non-athlete, and on concomitant injuries that and the time you get to get back. Now, the timeline for recovery is up to 5 to 6 months, so it's a long time. But most of our players, national team players, get back in about 5 months. The complications are clearly related to blood clot and also to skin abrasion with low vascularity in the area there, so low healing potential and infection and problems around the wound. So for that reason, we are very careful if we do surgery to have a look at blood clot and wound recovery. First, we knew in the past that this was stiffening up a lot, so many people went away from 2 months cast, and now we don't do cast anymore. We just do progressive boot and physio with heels, as we call it. So in the beginning, the patients get a high heel so that the tendon can relax and heal while we are walking, and gradually we remove the heels and we go into a neutral position over the course of about 6 to 8 weeks after surgery. The long-term effects on performance are interesting, because although we have healing in 5 months, we see that the return to previous level of play is sometimes up to 2 years after the injury. So especially in these injuries, they heal within 5 months, you play within 5 months, but if you look at your level of play and your performance, it can take up to 2 years in elite football. So how to prevent it? It's very simple. There are most of the time prodromal signs to an injury like that, which means you have some tendinopathy prior. So everything is related to prevention, of course, in these sometimes career-ending injuries, to make sure that once you have these little pains and nodular tendinopathies over the area, that we identify them, we treat them, we take the player out, and we make sure that they are back in the safe zone when they return to play before it ruptures. Also, very important, many players get cortisone injections there, and then the tendon ruptures for sure. So the number one key message is don't do any injections around the Achilles tendon for pain with cortisone. And then when to return to play, it's about 5 months, it depends. But in an elite athlete with big retraction, we would advise normally surgery. And then with the team in rehab and the boot with the heels, we get them back in about 5 months.